All right, welcome back, everybody. Thanks for joining in. Today, we're gonna talk about the differences between flexibility and mobility. And if you're training flexibility, but what you probably need to be training is mobility.
Hmm.
Uh, yeah, so kind of want to kind of clarify kind of define what flexibility is first, and then go through what mobility is. Josh, you want to kind of describe what flexibility is?
Yes, so flexibility is typically more the passive component. So whenever we think of flexibility, we think how far can we move a particular joint under an external load. So if I were to take you, lay you on your back, and raise your leg up, to 90 degrees, that would be the passive flexibility of what the tissues of the posterior chain can kind of allow.
Yeah, so flexibility is how far the joint can move under some sort of external force, whether it's you moving somebody into the range of motion or using gravity,
Correct.
and kind of like stretching on your own.
Exactly. Yep.
Uh, Mobility.
Yeah, so mobility is basically your active potential. So this almost is the not necessarily the opposite, but the active component. So we always have more passive flexibility at a particular joint compared to what the active component allows. So if we are in optimal ranges, we're going to have 85% the capability in the active range of what we can in the passive range. So the active component is really the mobility. So the movement potential of how you can move the joint.
So, the example I like to use is uh, if you can do the splits, that doesn't mean you can actually stand there and then pick your leg and move it up into the splits.
Right. And so a lot of times people, they could put one leg up on a box, they could put their other leg up on a box, but if we ask them to do the splits, it's like they can't. And then it's like, well, there's no muscle that crosses the pelvis that is preventing you from doing that, but it's your brain's ability to allow yourself to be in that position, just because one, you probably haven't done it, or two, it's been a very long time, and so it's if you don't use it, you lose it, right?
Yeah. So, what can you maybe touch on just a little bit about what you said the brain's not letting you do it? Maybe a little bit more.
Yeah, so the nervous system really is kind of controlling the tone of the muscle. So every muscle has a muscle spindle, which is a very small nerve that manages the tension. And so if the brain feels safe, it will allow the range to be a little bit greater. If the brain feels threatened, and it doesn't necessarily mean to, pain, discomfort, but for whatever reason, it just doesn't feel like it's safe, then there's going to be a limit in the range. So whenever we're taking someone through a range passively and we feel a limitation, we're going to get into this, but it's like we need to determine, is the nervous system not allowing the full excursion, or is it more of a tissue limitation preventing that excursion? In most cases, it's what I would call neuro-locked, where the nervous system is kind of locking down the range of motion for a variety of different reasons.
Yeah. Okay, so I just want to kind of give it a little analogy, kind of maybe give you a little bit more. So imagine you got like a 3-lane highway,
Mm-hmm.
and that center lane is going to be we'll say your active component, your mobility range.
Okay.
Those two outer lanes are going to be kind of what your limits of flexibility is. So how far you can kind of move passively, and then your median and your shoulder are going to be essentially like the very in ranges of that joint.
Right.
So you're always going to be able to essentially have more passive range of motion than active range of motion, and it really kind of depends on who you are and your flexibility and mobility levels are like. But if you're the type of person who's typically very inflexible,
Mm-hmm.
your distance between your mobility, your active component to your flexibility is going to be a lot closer than if you're somebody who's tends to be a little bit more hypermobile. You're going to see a much bigger gap between the active and passive component.
Right. And so, kind of coming back to that, the brain component. So, the brain is almost like the gatekeeper of your range of motion. So, in the person that's not flexible, there's a boundary that's it's not the nervous system. It's just the tissue doesn't have the ability to go through a large excursion. Whereas on the hypermobile person, like that person, they don't feel the boundary. So like there might be more of a neurological constraint to that range of motion.
Okay, let's go back to the person who's typically a little bit more or less flexible,
Yep.
and kind of talk about kind of what's limiting their flexibility. So I mean, it can be two different things: neurological and mechanical, and we kind of want to kind of tease out what this is and how it's different for each individual.
Yeah. So I mean, there's neural tension. So not even um, at the muscle level. Just so if someone herniates a disc and they have this nerve tension throughout say the sciatic nerve, and we then try to move their hamstring into a particular range of motion, the hamstring isn't going to be the limiting factor. It's going to be the neural tension in the nerve before you even get to the hamstring. So if someone's complaining of tight hamstrings, eliminating the neural tension. So someone that has maybe like carpal tunnel in the upper extremity, and then we put them in a certain range of motion, they might feel like numbness and tingling before we even put them into a stretch. So neural tension's a component. The joint capsule is a component. So at each particular joint, the capsule that surrounds the joint is a potential limiter.
And that's going to be kind of like your median and shoulder. So you're kind of like the in range of what that, like I can only straighten my arm so much before I reach upon the capsule.
Right. And then you have the actual bony architecture itself. So like at the hip, you have the acetabulum and then you have the femur, and everyone's hip's going to have a slightly different shape. You know, the general shape is going to be the same, but the orientation could be slightly different. So you might have a little bit more internal rotation or external rotation depending on how that orientation sits. So that could be a limiter. So we might see someone that has limited internal range of motion on a table test, but it could just be because of how their joint developed, right?
Yeah.
And so that's not something that we can really change or we should try to change. It's just kind of is what it is. And then we can get into the tone around the connective tissue that surrounds the joint, and then we can get into like the musculature and those types of things. So there's a lot of limiters, not just the fact that you need more stretching. Like I feel like that's typically the default is like, oh, I feel tight, I need to stretch. But why do you feel tight? There's a lot of reasons behind that, and it's not just the fact that the muscle's short.
Yeah, so let's go back to this tightness that muscle experiences. So typically, I guess if you were to say a muscle's tight, you could maybe say that's kind of going with mechanical tension, just because whenever you're elongating a muscle, you may have connective tissue dysfunction where you're not essentially pulling on the fibers equally. So why don't you kind of maybe explain mechanical tension a little bit more?
Yeah, so mechanical tension is basically the constraint of the connective tissue that doesn't allow the muscle to go through its full length. So if we were to take an ultrasound of the tissue, we would see potential fibrosis or disorganization in the connective tissue. So normally the connective tissue is going to have directionality along the lines of movement. And so under normal conditions, that allows the muscle to lengthen or contract. But if for whatever reason there winds up being fibrosis, some sort of scar tissue, that directionality becomes disorganized. And so that tissue doesn't have the same extensibility. And so what the person feels is whenever the force goes through that particular part of the tissue, they feel, oh, well, it doesn't transfer smoothly through that tissue, and it feels stuck. It feels limited, and it feels quote unquote tight.
And the degrees can vary infinitely.
100%. And it can be in different areas. So it doesn't have to be in one particular area. It can be in a variety.
The way I like to explain this to clients is imagine you have a bundle of rubber bands. You have like 30 rubber bands all in a row, like or side by side attached to the same anchor points. And then imagine you have like some glue that you put on a couple pieces of those rubber bands. So when you go to stretch the rubber bands, a few of those rubber bands are experience more tension sooner than the other ones.
Correct. Yeah. So if we were to like graphically represent like the slope at which the fibers feel tension, the ones that have the adhesion, think of that as almost like an elevator. So we're going to see this sharp spike in tension, whereas the normal process, it's almost like an escalator. It should be this gradual ramp of tension. And so that particular area where the fibers are adhered, if you will, they're going to just experience tension much sooner. And then that's what you feel as quote unquote tightness.
Excuse me. Okay, so staying on this mechanical tension. So how do you go about relieving some of this mechanical tension?
So typically, that would be an indication for some hands-on treatment in the early stages. But beyond that, that would be where isometric loading really comes into play. Mm-hmm. So we want to find the level of tissue as far as like depth. And so this is where you really have to kind of determine the joint angle, the joint position of where that tension occurs. You want to put that tissue under a certain amount of length. You don't want excessive, but you need a little bit of length through that tissue just to where you start to feel that first part of the stretch. And then we want to gradually start to learn how to ramp up tension through that isometric loading. That would be kind of the way to do it without like a hands-on approach.
So this is kind of going back to that whole loading at length, which we've talked about in prior podcasts.
Correct.
But this one you're kind of trying to, and I feel like if by doing some sort of like body control practice and being more in tune with your body, this is where it actually becomes very helpful, because if I'm stretching myself and I'm pretty in tune with my body, whereas you're stretching myself, I'm going to be able to experience or know when I'm starting to experience some of that mechanical tension much earlier, because I can feel it much better than you're probably going to be able to put your hands on me and experience it. So incorporating some body practice that way, so if you're trying to alleviate some of this mechanical tension, when you start to feel that initial stretch is kind of where you want to stop, and then start applying some like isometric loading.
Right. So we want to respect the barrier. So a lot of times we have this mindset of more is better. And so we'll find the stretch and then we'll try to get deeper, or we'll try to like stretch harder, more. So that goes back to the nervous system's kind of control of things. So even though we're dealing with a mechanical tension variable, the nervous system is still responding to what we're doing. And so if we go too hard too soon, the nervous system is basically going to kind of throw on the emergency brake. And even though you might feel a stretch, even though you might create that isometric loading, the likelihood that the result lasts more long term it's not going to stick. The nervous system's going to basically say, I don't like that, and it's going to kind of pull you back. And so what we want is we want to find that edge, and we just want to stay like right at that edge. We want to load, and then after we create that load, the nervous system should grant us a little bit more. And then we're going to go right up to that barrier again. And so it's a very subtle, it's not just blast away. You've got to kind of nuance it a little bit.
So yeah, okay. Let's put some parameters or guidelines on this trying to kind of essentially lengthen those adhesions and kind of get rid of this connective tissue dysfunction and bring it back to more in line, I guess, and functioning properly.
Mhm.
So you kind of take it to that initial level stretch.
Right.
As far as that isometric contraction you want to put into it, like, do you want to keep it lighter, and then like how long do you want to hold it for? Maybe give it a few
We could
guidelines.
probably do a whole podcast on this topic alone, but we would start lighter, and then we would see, does that grant us access to a little bit more range? So if we were starting with a percentage, so 10 to 30% effort is a good place to start. And if we get a little bit, but we really don't see much change, then the goal would be, let's go 30 to kind of 50%. Does that grant us a little bit more range? And so it depends on the athlete or the individual. So if we're dealing with a regular, not that there's anything wrong with it, but a regular person, they're less trained, they're probably going to need less tension. But if we're dealing with a little bit higher level athlete, someone that's got a higher training age, they're probably going to need a higher level stimulus to kind of get to that next level. So they might need that 70, 80, 90+% level of effort before we even see a noticeable difference.
How about duration? How long do you want to hold those contractions isometrically?
And again, it varies. We could be doing a little bit more repeated efforts where we're doing shorter duration, like multiple inputs. And again, it depends on what our goal is. But then we also could be doing like longer duration, like 30-second holds. And it all depends on what our true goal is. So the nuances is in what we're trying to achieve. So I couldn't give you a direct answer because we would have to kind of lay out some parameters of like what we're actually trying to target, because the duration dictates what we're going after.
But if you're at a starting point, you're not going to go wrong with going lighter and longer early.
Correct. Yeah. So if you wanted to do like a 30% effort at 30 seconds, you probably would be a good place to start.
All right. Okay. So yeah, and then also this is kind of talk about some manual inputs. Maybe let's kind of go back, tease out a little bit as far as maybe this is. I think this is where actually you could actually say foam rolling actually can assist, and where massage comes into play. At least from a mechanical tension standpoint, where an actual physical input can help with some tissue change.
Yeah, so I probably, like, traditional foam rolling would be you just get on the foam roll and you just start kind of rolling the general area. And you could start that way. But what I would suggest to maybe improve your ability would be find the area where it feels a little uncomfortable. And so that's probably where you're going to have some of that connective tissue disorganization. And then you could start to add in a little bit of that isometric loading. And so then it now turns into almost like biofeedback, right? So we've got the compression of the tissue, which would be the same thing as like me putting my thumb into the tissue. So we're going to have that slight deforming of the tissue from a compression standpoint. And then if we can then contract the tissue that's underneath where it's being compressed, we can use that internal force generation to start to enhance or load that tissue to then create some length.
So yeah, it's kind of like ART essentially. So it's wherever the particular spot in length of the muscle where the connective tissue dysfunction is, by putting an actual manual input into that, you can essentially force the stretch at that particular spot where connective dysfunction is.
We call it kind of like bowing the stretch. So like if we had a rubber band and we just stretch the rubber band, we would be putting tension through the entire length, right? But if I then took and I stretched the rubber band, but then I like pushed on it in a particular area, like I was able to, like, that's where the force is being funneled. So over the length of the tissue, there's going to be some stretch, but right where I put my finger, put my hand, we're going to actually enhance the stretch because we're bowing it to create even further length, if you will.
Yeah. Um, Anything else on mechanical tension?
No, I think that kind of covers it. So like the force inputs from the practitioner side or from the hands-on side, um, sometimes that can be discounted because I think the traditional mindset behind like hands-on is more just like pain relief. But I think in early stages of rehabilitation, um, the hands-on approach is guiding that tissue remodeling. And so if we can put a directional force into that tissue, we can prevent some of those adhesions from even starting. So we can actually jumpstart the healing process. And this is maybe a little bit of a different conversation, but we can actually jumpstart the healing process so that the disorganization is less problematic. And then we can actually get into some of the length loading that we talked about a little bit earlier, where you're doing it on your own much quicker. But a lot of times, like we were talking about this the other day, where you had a client where they didn't really feel the stretch, right? You were putting them in a position and you were asking, like, do you feel it? And it's like they really didn't. So again, that potentially would be the time where using some hands-on to help connect that brain-body connection so they feel the stretch where you want them to feel it, and then they go do it on their own and see, this is where we want you to feel the stretch. Now can you feel that whenever you're doing it on your own? Because sometimes like you send them away with an exercise or a position, and you coached them up really well in the office or in the gym, they go home and they didn't quite set it up the same way, and they're like, I spent all week and I really didn't. And so it's like, if we can allow them to feel the stretch and recreate that on their own, then the progress is just going to be that much better.
Yeah. Okay. So let's kind of transition into the other kind of big limitation in this, like this neurological tension.
Yeah.
And since we were just on it, foam rolling, most people are probably foam rolling for the wrong reasons.
Yeah.
You may foam rolling. You may actually, like, if you smash on a tissue, you're going to essentially kind of blunt the signal to it, so you're going to kind of not feel as much. So it may temporarily allow you to move into more range of motion.
Yep. Yeah. So all you're doing is you're tweaking the nervous system. You're just kind of giving it this down regulation. So if there was a certain level of tone that the nervous system was outputting to that particular muscle, you foam roll it. It now blunts, which is then going to give you like temporary access to a little bit more range of motion.
But that can be dangerous because now you have access to this tissue that you normally don't have access to, and then let's say you're going into more of like a max effort lift. Now you have this extra little bit of range of motion that is not essentially, it's passive, maybe passive range of motion, so it's not active, which means you don't have that force producing tissue.
Yep.
So now what causes injury, it's whenever the load exceeds the capacity of the tissue, the tissue is going to injure. So if you're trying to now then train that tissue at a higher intensity, this is where you can start running into some injuries.
Right. So if you have that neurological barrier,
it's there for a reason.
It's there for a reason. Yeah, we can get into that in a second. But so you have it, you temporarily remove it. So this new range that you opened up, it feels better. You feel like there's less tension. But when did you actually train that range? You haven't. So now you're going to go load up a bar and you're going to try to move into that range. You're setting yourself up for a potential injury. It may not happen today, it may not happen tomorrow, but if you're constantly needing to use the foam roll to open up range, you're setting yourself up for that injury.
In this kind of, I was thinking about this the other day. So, well, let's go to our hierarchy as far as movement. So whenever training a new tissue or a tissue doesn't have much force producing, you want to start isometrically, because whenever you're doing isometric contraction, the muscles aren't sliding over each other, so you're not creating any shearing force. So there's not really any inflammation that kind of really comes along with it.
It's the safest. Like, we can do that day one right after surgery. So
next, we have concentric.
Yep.
So it's whenever your muscles are shortening.
Correct.
And then some inflammation there, but most of the inflammation when we experience in the muscle is going to be coming from that eccentric phase.
Correct. Yeah. So the loading under length.
So whenever expanding into a new range of motion, best to start isometrically before we try to go high intensity. But if we're now training into that new range of motion with more intensity and then essentially creating more inflammation, since we don't have good quality tissue, like, we're much more likely to then, in like the repair process, because we're not able to tap back into it, the way that tissues, you're going to get some kind of like potential to get some fibrosis that kind of goes along in there.
Yes. So I think we talked about this in a different episode, but yes, that's exactly right. So
it's almost like a negative sorry to interrupt, but it's like a negative feedback loop that you don't actually really think about. You're like, I'm expanding range of motion, but unless you're able to like consistently apply force into that new range of motion in the direction that you want it to go, you're essentially going to kind of lay down some scar tissue, fibrosis, whatever you want to.
Right. So really, you could be thinking, I'm using this foam roll, I'm opening up range, then you're training, you're creating this inflammation in the range that you don't have access to. That lays down scar tissue. That closes down your range of motion. So over time, you're actually shrinking your range of motion, and you have no clue that that's even happening.
And it seems mind-baffling, but
yes,
it's just the way the body works.
Yes.
Okay, so we can foam rolling. That's saying foam rolling's, if it relieves some pain and it allows you to increase some range of motion, great. But then let's train that tissue in the order that it needs to.
Yeah. So just a quick. So static stretching gets a bad rap. There's some research done where people static stretched and then they did like a strength output, or they did like a vertical jump, and they saw that there was a decrease in force production. We all know that. But the same thing kind of happens with foam rolling. So like, even though you gain range, your force production kind of will be muted a little bit.
Well, yeah, you're, like we said, you're blunting the signal so you can move into more range of motion.
So now that same research was done where they did static stretching and then they did like a dynamic warm-up, and they were able to regain most of that force production kind of back. So if your sequence of events was foam rolling to kind of feel better, and then you had some other warm-up procedures like what we're going to talk about, you could potentially use the foam rolling as part of the warm-up, but I wouldn't suggest using it as like the only thing.
Yeah. Okay, so it's maybe, like I said, moving this neurological tension and kind of explaining, I guess, more in depth of kind of what that is.
Yeah, so neurological tension, I would say the neurological tension, like I said earlier, is the gatekeeper. So while we do have mechanical tension, like in the clinic, I run into more neurological tension than I do even though mechanical tension is all over. But on a day-to-day basis, whenever I see a limited range of motion, it's first neurological. Because like, if I'm testing hip range of motion and I feel like, oh man, this guy only has like 10 degrees of movement, I can't truly tell you how much mechanical tension is in that tissue because I can't move the tissue. The neurological system is basically just limiting the range, right? So that's again, maybe another conversation for another day, but this brain's lockdown of range of motion kind of dictates everything, really.
Yeah, it's like, I think it's your body's own built-in defense mechanism, because it's if your brain's locking you into a position to prevent you from going in, it's probably because that tissue that you're trying to move into is not really good. It's not, you don't move into it often, so it's not going to have force producing tissue. It's not going to be able to absorb forces, so you're usually going to be a lot more susceptible to injuries.
Right. So I know we've put this graph up in other podcasts, but it's kind of like this bell curve, right? So the tail ends are short or narrow, and the end ranges are where we tend to have injury, right? So if we're moving into those end ranges and the brain for whatever reason doesn't feel safe because it doesn't have the ability to produce force, it's going to narrow that up. Talking back to your lane analogy, so instead of the lane being the normal width, the lane starts to shrink a little bit because that's the zone of safety, if you will.
Yeah. Okay, so neurological tension, just to clarify, no amount of foam rolling or massage. It may, like I said, blunt that signal, but it's not going to create any sort of long-lasting change.
No, like neurological tension. And so this is another little like side point. Neurological tightness is the brain using the nervous system to basically create like a partial contraction to limit the range of motion. It's not the same thing as mechanical tension. So tension is a lengthening or the ability to lengthen concept, whereas the mechanical tightness is a construct of how the nervous system is reacting to the tissue. So again, it's might seem like semantics, but there's really a nuance of difference there.
Okay, so let's talk now. Kind of move into how do we kind of remove and get past that neurological tension.
So again, it comes back to isometric loading. Surprise, surprise. So it has to be active. That's the main thing, where we can passively load a mechanical tension, and then we can put that tissue under length to create change. That's not the case with neurological tension. Neurological tension, we basically have to use the nervous system to contract the muscle to basically create safety in that zone to allow for the brain to grant you additional access to that range. So you create the isometric contraction, you do that once or twice, it's going to grant you, so like P&F stretching is a common, you create a contraction and then you try to lengthen, and it's like, okay, now I can lengthen a little bit further. Interestingly enough, if we take EMG electrodes and we put it into that muscle, we actually see higher levels of contraction, even though we now have the ability to lengthen. So interestingly how that works. But long story short.
So you're talking about from a performance standpoint? Like you're actually able to put more force on that after the PNF contraction?
Not necessarily. No, so you would think if there's a limit to range of motion, and if it's neurological, so the muscle is contracting to prevent the lengthening from occurring. But if we then create a contraction, and after that contraction, the brain allows for some lengthening. But if we tested like the resting tone of the muscle, it's actually going to be higher. So you would think a higher resting tone, it shouldn't be able to shorten, or I mean, it shouldn't be able to lengthen. You would think it would be shortened, but it's again how the nervous system is responding, because it doesn't really want you to fully go into that range yet. You have to do this over repeated efforts, over consistent days, for it to truly grant you that access on a consistent basis. So with PNF, we see temporary changes, just like we see with foam rolling. But if we don't truly lock it in with more mechanical tension inputs, we won't see that on a lasting scale, if you will.
So then maybe you're then also adding this active component to really create this lasting change, and also to then maybe speed up the process and also maybe create more range of motion. Maybe then this is where we kind of start adding in some of that like opposing contraction. So like the tissue that you're trying to lengthen gain a little bit more now by using, since you've overridden that stretch reflex, using that antagonist muscle to then contract and try to now move actively into new range of motion.
Exactly. So if we use, so if we put a tissue under length, so that tissue is being stretched, right? And then we create a contraction, and then we try to lengthen it even further. So the tissue that we're trying to lengthen, that first contraction allows for a little bit more length to occur. And then the opposite, from a neurologic standpoint, helps to like lock it into a, or like if we're thinking from like a Microsoft Word document standpoint, it's like hitting save on the Word document.
Yeah, so it's PNF where you're getting stretched passively, then you add that active contraction at length into it, and then instead of where in PNF you kind of are then passively moved into more range of motion, now you're trying to actively move into more range of motion since you've overridden that stretch reflex.
Correct. So you use that temporarily ability to go into that new range, but now we want to actively create that contraction into that new range. And in the beginning, we don't want to load this up because it's new. So this would be where we're just trying to do this under body weight. And then gradually we might start to add some very low external load, but that wouldn't be something that we're going to jump to right away.
So yeah, for the most part, kind of like mechanical, you're definitely going to want to start light, like a light contraction at first, and then gradually ramp it up to a high intensity, because in order to create change and actually be able to create more range of motion, essentially remove some of that neurological tension, it's going to take a high intensity output.
Yeah, so if we look at like force and like maximum or it's basically 70+% of the ability for that tissue to contract. If it's below that threshold, it's probably not going to make any long-term changes. We need to ramp it up above that kind of 70% contraction rate.
Yeah, and then also kind of talk about, I guess, what's worth mentioning there is when you're kind of at your end ranges. So going back to that bell curve, we're not gonna have as much brain muscle connection. So
yep.
You're probably not going to be able to, even whether you wanted to or not, you're probably not going to be able to, because it's essentially untrained tissue. It's the bottom of the bell curve. Mm-hmm. You're not going to be able to put like a full 80 plus, 90 plus max effort contraction into that.
Yeah, so you're going to feel like this is everything that I've got. But if we were measuring it, it would be like 30% or whatever. So while effort is important, like I want you to use everything that you've got, it takes time to truly develop that 70% at those end ranges. So even though it feels like a hard effort, it takes time to be able to develop a true max effort.
Yeah. Neurological tension. Anything else on neurological tension kind of versus mechanical tension?
Yeah, I just think that a lot of times whenever you feel that tightness or you feel that tension, it's going to be that neurological tension first, and then once we kind of open that up, if there's still some potential restriction to the range of motion, that's whenever we would start to see more of that mechanical start to show up. Because if the range of motion is limited, you're not even going to be able to like create length in the tissue. So you can't say if it's mechanical yet. So typically it's neurological first, and then we're going to start to see some mechanical.
Yeah. All right, let's move on to kind of this, when you're trying to improve your mobility, you really kind of shouldn't use it to like a warm-up. It should be its own separate thing.
Yeah. So we see this all the time. I mean, you can go on the internet, you can go to any gym, and they're doing, mobility drills to warm up. And it's like, well, you're not going to gain range of motion in 15 minutes before you go do your workout.
I mean, so let's say there may be you are getting blood flow, you are maybe warming up a little bit of core temperature, but you're not improving your range of motion.
Yeah. So if we see improvements in range of motion, it goes right back to what we just talked about. It's the blunting of the nervous system, and it's that neurological inhibition is lifted just a little bit, so we can open up range. But technically, you had that range, but you don't have access to it without this procedure first, right? So it's not true change, but the long story short is, if we're trying to enhance mobility, mobility needs to be trained separately than strength. Like, it's its own thing. Like, it's its own quality. So I think that we just throw like movement or mobility as like part of the workout, but in reality, it's its own trainable quality that is separate from strength training.
Well, I can think of it. So if you're been working out for a while and you're pretty experienced, if you do like a 50% workout, you're probably not going to expect that you're going to get any results from that actual workout. It's in that maybe detraining zone, retraining zone. It's not a stimulating effect. So that same principle to your mobility, treating that like your warm up is not going to create more mobility. It's going to feel like a max effort deadlift in order to create that change that's needed.
Yeah. So if I hired you to be my trainer, and I said I need lower body strength, and if I use your example, if we only did 50% effort, and then I said, well, I want to get to a particular number, and I'm like, why haven't I achieved it? And it's like, well, we never achieved the intensity to get to that point. I might have broke a sweat. I might have felt like I did a hard workout, but I actually didn't get to the right signal to create the change that we're looking for.
Yeah, and I think, I guess people, it seems, because it's not, I guess, common knowledge, and it's not mainstream, but giving yourself actual, like, true separate mobility workouts, we may be limited on time, and we may have so much time, but by giving yourself more force producing tissue, this is like maybe a whole separate topic, but more mobility and more force producing tissue at those end ranges, it's going to take a lot less volume, and it's actually going to be a little bit, sometimes maybe more beneficial time than just getting extra reps in.
Yeah, people are always looking for a hack, right? Well, you can't hack these changes, but what you can do is, by improving your active control in these ranges, whenever you go back to the lift, you're going to be able to create more force over a longer length, which is then going to make the squat or the deadlift or whatever exercise you're going to actually create more load through the tissue, which will give you better results, right?
Yeah, it's like hypertrophy for range of motion. Just give yourself more biology to use and what it is that you're wanting to do.
Yeah, so I think that like, you see these people doing like mobility, and it's just movement. There's no real rhyme or reason. Oh, I need to train my rotation. So you see these people doing like, the almost like a cat camel, but with like a rotation. And it's like, you're just moving in the area that you can already move. You're not moving the stuck area or the limited area. You have to put yourself in a very specific position that targets where you're limited, put a high amount of force into that tissue, gradually open up range and then start to train it in a very specific way. But if you see these, warm-ups, there's very low intention behind it. It's just, again, it's kind of fluff. And while it might increase core body temperature, you're moving the body, you might be priming the mobility that you already have, but you're not really creating long-term changes that are going to lead to improved mobility over the long haul.
Yeah, and let's just say, so you mentioned something there, and then it's definitely worth mentioning. So you like the priming. So doing mobility, not saying you shouldn't do that, but of course you should add more variability and degrees of movement. But like there is benefit to maybe it's maybe reframing your mobility workout instead of thinking of it, you're actually going to increase your range of motion. Just more like you need to prime the tissues that you may use later.
Yeah, so there's clearly a reason, so like if we're going to go out and play golf or just go to the range, hip rotation, thoracic spine rotation. So we could do some drills or some movements or some exercises that target that. But my intent is not to open up additional range. I'm basically, if I've been working at my computer all day and I feel a little stiff, I'm just trying to like regain some range that I might have kind of lost throughout the day. But technically it's still there. It's just kind of that playing with the nervous system. But if I was truly, if we went and we did like a TPI, which is like the Titleist Performance Screen, and they have all of these different tests that they do for ranges of motion and strength and all that. And if they said strength wasn't my issue or your issue, but thoracic rotation to the right because our backswing's a little short, there would be very specific drills and where we would want to put that into our training, in addition to using that as part of the warm-up as well. So they're separate, but also if we know that that's a sticking point, we would want to use that. And so it's like we're trying to say that it's different, but we're also saying that it is needed as far as like potential warm-up as well.
Yeah. So yeah, mobility, flexibility, by focusing kind of on that in-range training, we can then slowly work to kind of like expand that center lane into those outer lanes, and we're trying to kind of bridge that gap.
Yeah, it reminds me of that Seinfeld episode where Kramer takes the like lacquer thinner or whatever and like widens the highway.
Oh yeah, I'm trying to remember the context now of that. Of why was he doing that?
I don't really remember, but it made me think of it.
Oh. Yeah. So in order to widen that center lane, it's going to come with intensity.
Right. So getting back to that, just really quickly. So if we just do that passively, you might improve your width or your lane or your range of motion, but it's not necessarily going to lead to usable range. So I don't know if you remember in that episode where he widens the lanes and then it's a traffic jam, right?
That's right.
And then Newman comes and there's that sewing machine, and
is that the one with the golf clubs?
I think so, but anyway.
Okay.
But anyway, so creating passive flexibility isn't necessarily going to give us usable range. So we can sit there and hold these passive ranges of motion, but it's not necessarily going to be trainable in the gym per se.
Yeah, not force producing tissue. So by adding intensity, kind of, or adding those contractions at the end of our kind of passive range of motion,
right.
We can override that structurally flex, but we're also now gaining more force producing tissue at the bottom of those bell curves.
Right. Yeah. So we will see that slowly kind of bump up, which will actually make the whole graph start to enlarge just a little bit as well.
So I like to tell everybody, like, who's like new to whole stretching and mobility, like you can't really go wrong with like doing a passive stretch and then trying to do a contraction at length, starting light.
Yeah.
It's a great starting point. So if nothing else, start with that.
Yeah, and so we can't discount passive stretching, because if you need length, we have to first do it passively. But then if that's all we did, we would be leaving a lot on the table. So we have to then contract in that lengthened position.
Passive stretching is going to give you passive results. So
Exactly.
If you,
So
if you want the active component,
you have to
do it.
Yeah.
Yeah. Anything more? Mobilities and range of strength. Yeah, I think if we all maybe kind of started to kind of conceptualize, like, you're kind of adding like the amount of effort you put into your your 1 rep max deadlift, and then applying that into our mobility, we're going to see much quicker results, and preventing off injury, and just a whole other list of benefits that we've mentioned.
Yeah, I think that the general misconception is that mobility is this easy thing. But if we're truly trying to change range of motion, we've got to use the same intensity that we're trying to use to change strength to change range of motion.
Yeah, like I people who say, oh, it's not that hard, it's not that much work, then I guarantee you're just not either. Like we've mentioned before, you don't have that ability to create that amount of force, because you're not used to training those in ranges. So it's probably not gonna feel too hard. But once you've kind of unlocked it a little bit, and then you're able to go up to a max effort, when there are what we call a rails contraction, regressive tissue contraction. I mean, you're gonna see heart rate spike. You're gonna be gassed afterwards.
Yeah. So there are people who I've trained where it's like they would rather go deadlift because the position that we put them in was so difficult.
Well, yeah, at deadlift, you're comfortable. That's your sweet spot there. But then you go to something like those in ranges where you don't have that brain muscle connection.
Yes.
And you go to ask somebody to work as hard as they can. I mean, it's a lot like doing a 1 rep, because you when you do those max effort lifts, it's like how you kind of feel fry afterwards, because you brought so much brain into the game, that you're just drained and you're kind of feeling sluggish afterwards. The same thing with mobility training.
Right. So expanding capsular space, the only way to improve that is through a max effort contraction. So if you're not bringing that level of intensity to your mobility, I'm not saying that you need to do that all the time, but if you're not bringing that to at least 1 session, 2 sessions a week, you're probably not seeing the results that you're looking for.
All right. Anything else you want to add?
No, I think that that sums it up pretty good.
Bring it.